today about how to organize another chronic heart disease unit. So Niki is the clinical lead of the other chronic heart disease unit in Glasgow in the Golden Jubilee Hospital. And she's a friend. I don't like her very much lately since she has stolen doctor's home for us, but good for her program. And so Niki, thank you for joining us, and the floor is yours.
So Rafa, thank you so much. I am sorry about Lorna, but I'm really not. She's a great colleague, as you know. So I know that you achieved your revenge with this title, which is quite something to try and consider and describe. So I tried to reframe it, and by the end of the talk, I would hope you'll understand why I think this is perhaps a more appropriate title that we can try and work towards. So I have a few disclosures. I have opinions but not answers. My opinions may well be wrong, and I probably have more questions than I actually have as answers. So we can try and work through this. And I think the key theme at the end of all of this is that you will know what is best for your location. So talking of Lorna, I caused her great offence by showing her these images and suggesting to her that these were two very valuable Christmas trees, but each suits their own environment. The one on the right is in my house and captures the history of many years of nursery schools and goodness knows what. So it is about what's best for your location. So over the course of the next 45 minutes, I'd like to just consider around the adult congenital heart disease specialist care. Why are we talking about that? What is it? Where would we want to be thinking about locating it? And also just some other more diverse comments to make around that. So when one looks for why specialist ACHD care, I suspect to this audience it seems rather obvious. When you ask the patients why they want specialist care, is because they want to feel safe. They want high quality care. They want high quality care from experts who understand their heart, and they want care as close to home as they can achieve. There's this lovely piece of work from Dr. Morelli's team, which it's back in 2014, but it's a stunning piece of research. And what they comment on is that they noted that with the publication of the consensus guidelines, there was a significant rise in referrals to specialist ACHD care. And you go, that's great. But what's stunning is the impact that had on mortality. So looking at this slide, you can see the introduction of the guidelines here, the upturn in referrals to specialist care. But look at that, the downturn within a short period of time in mortality. We don't have many proven therapies within congenital heart disease, but if this was a drug, can you imagine the marketing spiel that would go on around the marketing of this kind of drug, this potency of effect? And this is to do with coordinated specialist care. So I hope that I've convinced you around the why we want to think about ACHD specialist care. So let's quickly touch on what is ACHD specialist care. Now in the UK, we have a national health service. So that is a government funded healthcare service that is free at point of care and accessible to all our population. Therefore, you would have hoped we could organise our care more effectively, but we now sit at the end of what I hope has been a bloody battle, but that's over. This document came from 2011 when they were trying to reconfigure services. And this was based around the theory that we should be having high volume specialist centres, mainly around congenital cardiac surgery. But the challenge they met was that whilst lots of people could say that that's what they agreed with, they wanted their service to maintain their role in that performance. After much discussion and an incredible piece of work by NHS England and their services, they achieved this standards and specifications for congenital heart disease services within NHS England. And so what these standards define is what a service should look like, what it should include, and that's everything from personnel to resources to access to diagnostic tools, access to inpatient care, outpatient care, and also what different levels of care should be around the country. So there is this notion of level 1 specialist centres, level 2 non-surgical centres, and level 3 local centres. And these were published in 2016. And then in NHS Scotland, because we are a devolved nation, we of course had to rebrand it and call it something slightly different. In essence, we have our own guidelines from, our own standards from 2018. But even in that short period of time, within 4 years, we're already looking at the standards and specifications and challenging things like the number of surgeries that are mandated to be named a congenital cardiac surgeon or congenital cardiac interventionalist. But this documentation of standards and specifications in terms of trying to plan a service has been incredibly powerful, and has also led to the potential for development of quality assurance projects and quality improvement projects, really to try and improve that care for patients. So hopefully you believe that standards are very helpful in trying to define what an ACHD service should look like. In terms of what is an ACHD specialist, so in the UK, we have regulated training that defines what kind of cardiologist you end up. There's very clear guidance as to what a specialist is, and a specialist in ACHD spends at least 80% of their time looking after patients with adult congenital heart disease. Cardiologists with an interest in ACHD spends less than 50% of their time looking after patients with ACHD, but all of our trainees have to have exposure to ACHD to achieve their credentials for cardiology training. And there's similar programs with board certification in North America and the like. So the definition of what makes an ACHD specialist is hopefully becoming quite clear and quite transparent around the world. So when it comes to trying to think what your ACHD program is going to look like, this is a lovely paper from the team in Houston from 2018. And I love the language of this, where they look at what are the critical components, and as they phrase it, the important allies around this. Now, some of these are very translatable in terms of any service, in terms of you need to know in terms of the hospital environment you're going to work within, the interfaces within adult and pediatric care. But some of them are less translatable perhaps to my form of healthcare resourcing, where we're not having to specifically pursue and clarify revenue streams. But it really is a very helpful paper that just tries to capture all the different components. And within that, they highlight that not every ACHD centre is going to look the same. And so it is very helpful if one can consider from fairly early on how your ACHD centre will sit within other ACHD centres in the area, the region, the country. So for example, in the UK, we're a specialist ACHD centre here in Scotland, but we do not take on, for example, fontan transplantation or deep cardiac transplantation within the congenital population. That's despite the fact that I sit within a centre that performs cardiac transplantation. There is an acceptance that this level of specialist transplantation is best performed in a centre that is achieving high volume to ensure that we get the best outcomes for the patient. So it's just worth considering what level of service you're seeking to set up, establish and maintain. So looking into the how are we going to then deliver an ACHD service, these two documents, which are republication of ACHD guidelines, have, you know, they're fabulous documents. They've been really beautifully rewritten, recrafted, and they really now function as guidance for us all to try and deliver and devise care pathways for each individual patient with their individual condition. And it's starting to work around instructing scheduling of routine follow-up, imaging modalities, timing of interventions, and all of this is obviously on a guideline level, which one then has to individualise the patient. But these are incredible resources in terms of trying to plan your service and the likely need for service capacity for diagnostics and clinical resource and the likes. So finally, not finally, but now we've managed to move on to the team. And you know, when you're trying to work within a team, you always want to perceive that you're working within a world-leading team. And that team is huge within ACHD, and it's part of what I probably enjoy most about ACHD is the team aspect, and that team includes obviously the patient, but also the wide collaboration that we have to try and ensure best care for our patient groups. So we've spoken already about what makes an ACHD cardiologist, but we all know that we also need ACHD cardiologists with an interest in electrophysiology, imaging, heart failure, intervention, pulmonary vascular disease. And these interface very closely with our cardiac surgeons, who again, it's congenital heart disease cardiac surgeons we think of first. But as we work with an aging population, the need for general cardiac surgeons, for example, for bypass grafting, for coronary artery disease, or interfacing with transplant mechanical circulatory support surgeons. In the UK, we're very fortunate to have a very well-established and defined nurse specialist role. So these are nurses who have advanced practice. So they have clinical examination skills, prescribing skills, and they work within our team. They are full-time members of the team. They run clinics themselves. They are part of the multidisciplinary team meetings around decision makings for patients. And these really are key supports in terms of really delivering care to our patients. And they're often the first interface with our patients to try and ensure that they have clear communication pathways. Our service obviously also needs high volumes of imaging with radiologists. We're utterly dependent on our cardiac anaesthetists, cardiac intensivists, and then all the team around that with radiographers, physiologists, physiotherapists, and psychologists. And very important within that is recognition that you need an operational management team. So the people that are actually doing the management planning, service planning type facilitation, but they have to understand that adult congenital heart disease is a very different model of care compared to, for example, general cardiology. And that's in everything from the duration of a cardiac catheter. So there's no point in comparing my catalysts with a coronary intervention catalyst. Similarly, there's no point in comparing my clinic duration or my clinic appointment duration with someone who's seeing somebody with chest pain back again. And it's having the compassion to recognise that the different needs of a service is very important. In addition, we need an increasing number of support specialties. And this is everything from looking after the liver, the lungs, the kidneys, surgical needs in terms of urologists, general surgeons, and also obviously obstetrics and gynecologists. And most important of all, your ACHD service is going to need patients, and it's finding to ensure that you have access to a patient pathway that involves integration with our paediatric cardiac service teams as well. So here is our team, and it's a very exciting and very different place to where we were even this time last year. We have 3 surgeons, Mark Danton, Chuck McLean and Ed Peng. I'm very fortunate to work with Amanda Hunter, who's one of our new cardiology consultants who trained here and in the Brompton with Rafa and Lorna. You know Lorna Swan rather too well, I'm afraid, and I'm absolutely delighted that she's joined us over here. And Grushin, who's on the call today, has just arrived back from Riyadh, and I am very excited about working with him from the turn of the year. Hamish Walker has joined us again from Leeds, and this is the wider team. I tried to take a photo, but of course with the COVID pandemic, barely fits in the screen these days. So hopefully I can convince you that we need a wide-ranging team. So thinking about where we should be trying to locate the care, it's a very challenging one in that from a patient's perspective, they would pretty much like it on their doorstep much of the time. But from a centre perspective, you would ideally like what one might call triple co-location, where you're co-located as an ACHD service with your paediatric cardiac service, and in addition with your adult general services, so that we can access all those specialists we mentioned earlier. You also want to be co-located with good rehabilitation, excellent imaging, and also a research institution. When thinking about where your patients are coming from, this is a piece of work that we've been trying to do in Scotland to try and identify standards for our local centres. And this is a comment from one of our patients who comments that standards for local care provision are essential from her perspective to ensure that patients have access to safe, equitable and consistent care. And this is an ongoing piece of work that really has been exciting to work with. So within Scotland, our patients live across Scotland. So for a brief geography lesson, Scotland is basically north of that line there. And this is Shetland right up the top here. Norway's just over here somewhere. So we're based in the west of Scotland, and each of these red dots is where we have a shared care team. This networked cardiology care, so this is with a specialist centre and then local centres, really came into being after the work of Jan Burns, one of our paediatric cardiac cardiologists, who was working as the patients were coming through into adulthood and recognised the need for adult congenital cardiac care. And so she worked with the local teams to ensure that the patients transitioned from their paediatric services in these centres into the adult services. And she maintained the liaison across these roles. Since her retiral, we've had the opportunity to expand and extend these roles. Our local clinic cardiologists are obviously individual cardiologists of their own right. Most of them are imaging cardiologists, so they're closely related to the echo surveillance of these patients. They all look after their own clinics, perform their assessments. They facilitate the local care for both planned and emergency attendances. So they're often the first person that's called if the patient comes in with acute cholecystitis. But in addition, they act as the liaison and escalate to the correct service as and when the patient needs. And this is very much in line with this comment from our standards, which is that we have been tasked with facilitating the development of as much non-interventional care and treatment as close as possible to home. To try and facilitate this, we run outreach clinics from the specialist service where we attend in person, where we see patients together often, where we share with reviewing imaging. We'll review inpatients. If there's cardiac obstetric patients, we can review them and see transition patients. One of our nurse specialists attends the clinics also to again try and ensure that they get as complete an experience as possible and access to as much information and education as we possibly can. In addition, we take all of the referrals from the local teams and present that data at our multidisciplinary team meeting. So in other words, we take their interpretation and assess how best to then progress the care. Our multidisciplinary team meetings are held physically in the hospital in Glasgow, but with a Teams link that we would try and encourage our local cardiologists to attend, because obviously they've met the patient, they know the patient, and that information is incredibly important, trying to make the right decision for that individual. To try and support this network care approach, we have, as part of our commission as a specialist service, a mandate to maintain an education programme. And so this really translates as an annual conference in addition to the outreach clinics. And we try and make sure the communication is as easy as possible. So, for example, the team know all our phone numbers, they can phone us, text us, email us. It's all as easy as we possibly can. Now, I'm very conscious that I'm talking about Scotland, and Scotland is a large territory compared to many of the English regions. But this is a map that I found online last night, which puts Vancouver Island over the top of the UK. And for those not with Canadian geography in mind, this is Vancouver Island here, and this is Canada. So my problems in terms of trying to achieve an outreach programme are minuscule compared to what is necessary in other environments. And again, I come back to this notion of you've got to look at what's best and appropriate for your own geography and requirements. This is one of my favourite quotes from this paper that mentions about important allies, and it highlights that when we're trying to work with our team, with network team and the likes, it's trying to ensure that we have a culture that ensures that we have education and easy communication. And I think that's a beautiful way of expressing it, that the referring physician education, it's the culture that's critical to actually deliver this. So that's what our conference programme looked like just last week, and this was a virtual clinic this time round, but normally we have it as a face-to-face clinic where we have a lunch for all the referring clinicians. We extend this programme out to all our trainees, to really anyone that wants to attend. It's free to attend, And it's just one of the ways that we try and ensure that we maintain the dialogue and keep topics up to date for our referring teams. And if I can try and give you some sense as to why this notion of network care is helpful, I'll give you two examples. One is the ongoing COVID pandemic. Now, the COVID pandemic has wreaked havoc on healthcare everywhere. Within Scotland, many of our patients would attend clinic by travelling on public transport, which has been one of the ways in which transition of the COVID virus has been more common. So patients have been trying to avoid public transport. They've been able to attend their local centres. So their local centres have been updating their diagnostics, ensuring that they can access Holter monitors, that sort of thing. And by using that resource, we've been able to maintain ongoing care for many of our patients, so that only those that really need to travel are travelling to the centre. At the same time, it's meant that our local clinicians have been able to highlight if patients have had acute admissions, if they need brought into the specialist centre, and that dialogue has been incredibly important. As a different form of network, I'd highlight that COVID has also gone on to show the need for regional networks. So instead of thinking about the specialist centre and the local centres, we've within the UK developed regional groupings. So we've tried to ensure resilience in case of COVID pandemic affecting surgical teams or cardiology teams, so that we have close communication with, for our centre in Scotland, we communicate with Newcastle, Leeds and Liverpool to ensure that if any one of those teams was suddenly struck down with COVID, we could all cope to look after the patient cohort, irrespective of that. And again, I'd highlight that the likes of these Toronto Grand Rounds have been an incredible opportunity to maintain that network, to share knowledge, information, to continue teaching despite the limitations of the COVID pandemic. So I think network is a very diverse language that covers everything from local teams to international collaboration. Second reason I would stress the benefits of the networked approach is from this paper from Baumgartner, where you see this population coming through of geriatric cardiology, as they chose to describe it. This is a cohort of patients who are going to have increasing needs, and where many of their needs are acquired cardiology driven. So having experts in acquired cardiology, which is what our local cardiologists are, that's incredibly valuable to these patients to ensure that they have streamlined care to access the correct type of cardiology care going forward in the future. It also is an opportunity where we're going to have to think about how we're going to care for all these patients, this increasing population of adult patients. And certainly within our model, we are hoping that we can try and ensure that the patients that need to come to the specialist centre access a specialist centre, but that we can try and ensure that much of the care is maintained locally by increasing the amount of moderate complexity imaging that perhaps happens in the local centres. So this is from another of my favourite papers. You're seeing all my favourite papers today. Another of my favourite papers, which again is from Dr. Morelli, where she highlights the population and the increasing population of adults with congenital heart disease, which is an incredible success story around the world. The editorial that came with it has this wonderful descriptor where we're blindly feeling for this charging elephant, which is a description around the lack of infrastructure around adult congenital heart disease services. And this is what I mean, that I think a networked approach is the way that we can establish and maintain an infrastructure that looks after our patients, that ensures that there are safety nets in place, that they're not going to get lost to follow-up, that they're able to access follow-up, but access follow-up in the correct location with escalation at the correct time. So I hope I can say to you that network care is a very attractive option for our population in particular. I would say that it's not without challenge, and within an NHS system where we have government funding, there still isn't good funding for our local congenital services. And that's something that we're having to carry on and continue to work for, to try and define funding streams that will look after these local services. There's other questions around it. For example, what's the governance of an outreach clinic? Whose clinic is it? What's the responsibilities for care? And even simple things like, if I do a clinic 4 times a year in Inverness to maintain an honorary contract in that area just now is a human resources challenge beyond solution. So other aspects of ACHD care that you need to consider if you're building this ACHD service are around quality, quality assurance and quality improvement, and also around progress and evolution. So within the UK, we have a real culture of trying to ensure that we're looking for patient impressions of care. So it's about patient-reported outcomes of patient-reported outcome measures, these PROMs, or patient-reported experience measures, these PREMs. Now, all of this is based on having good data where you're able to access your patients and ask them about their experience. The additional way that we're trying to ensure quality of care is, since the standards were developed back in 2016, there's been a governance process that's supported the development of peer review of centres. So last year, each centre was visited by a representative from NHS England's quality surveillance team, but supported by clinicians from multiple different centres. So you would have a cardiologist from one centre, a cardiac surgeon from another, specialist nurses, patient representatives, who would all come and review a service. And it was a two-pronged review. One aspect was to ensure the service was meeting the standards, and the other was to look for opportunities for different ways to deliver care so that we could try and share best practice so that all the centres are seeking to try and achieve the best possible for the patients. At the same time, we're very conscious of the need to try and maintain quality outcomes, and to try and assess for quality outcomes, we submit all our data around any surgical or interventional procedure to the National Congenital Heart Disease Audit. And this again has a validation of data aspect and then publication of everything from, it's been very mortality focused to date, but they're now trying to look at non-mortality outcomes to try and consider how best we can improve the outcomes for patients. But I think there still is a huge challenge that we don't really have a good way to define what is a good outcome for a pulmonary valve replacement, for cone repair for an Ebstein's. Yeah, we're needing to come up with ways that we can measure and be able to define what is a high quality outcome for each of these different conditions that we treat. All of this has developed a real sense of rigour around service provision, and there's a real culture of high quality about surgical provision, about interventional provision, where we are seeking to minimise any error. And I think that really does raise a challenge that if we're running ACHD services, how do we achieve evolution of care? I was very sad to hear of the death of William Norwood, and looking at his paper really brought to mind the question, in the current climate around surgical provision, would we manage to develop this kind of very novel approach, this at the time very high risk approach to surgical intervention that has been of incredible benefit to a whole population of adults now? But we need to ensure that we have a service model that allows that development and design of new techniques and approaches. So finally, I would suggest that an ACHD service really does need to have an absolute foothold in research. And research is of all types. I would bring you back to that very first paper I showed you, where the result of research into the outcomes of implementation of guidelines shows incredible potency of effect. But we need to try and work as a collaborative group. And again, this is around network of care. And I think the International Society for ACHD has been really a stalwart in trying to establish this network. When you look at how it's developed and evolved, I was looking at their website just last night, and there's forums there that if you're a single clinician, you can ask questions of the world's experts on the ISACHD panel and share expertise and questions, and that's an incredible resource. and we have to use that whole culture to try and take forward research topics around ACHD to try and advance and keep advancing the care for our patients. So I hope that I've managed to convince you that when thinking about how to organise an ACHD unit, we understand why we're doing it, because it saves lives. We understand what it is in terms of the personnel and the people involved. We understand that the location is going to have to be very system specific, and that there's many other aspects that one needs to consider in terms of how to ensure quality and outcomes for all of our patients. And so I would suggest that this networked approach, from everything from local care of patients right the way through to international research programs, is the way that we're going to tame the charging elephant of the increasing population of ACHD. Thank you very much.
Thank you, Niki, for the great presentation. So if anybody has any questions, yes, you can either unmute your microphones or can use just type them in the chat, and we can and you can ask them. When people thinking about the questions, Niki, I have one question. So I really like the idea that of having a network of centers. I think that the specialized centers cannot keep doing what we are doing. Yes, we cannot keep looking after every single simple and moderate risk congenital heart disease. But having a network center is perfect. But how do you, apart from having annual meetings for training, how do you keep or maintain the training of these people, or start the training? Because actually the most important or the most difficult part that I find is finding people that are really have interest in congenital heart disease, and they are able to look after these people, because as soon as they get interested, to give their training is easy, but to develop their interest, I find it that challenging.
So we've been really lucky. We have, so I inherited a number of well-established clinics with clinicians in post, and over the time that I've been back in Scotland, a number of them have retired, but they had such passion for the patient cohort that they had already anticipated the need and had, forgive the language, almost groomed somebody into position to take on that role. And so that interest, that passion, is what we need to try and engender and ensure. And I think that to go forward with that, we are trying to ensure that we see our trainees very early on, almost as soon as they say that they are in specialist cardiology training. We try and get them to come and spend at least 2 weeks with us at the specialist centre, where they can see the range of conditions. They can see the way that it, the way that ACHD allows you to be the ultimate and general cardiologist, but with access to incredible patients that keeps you thinking, that gets you access to imaging, to intervention, to true collaborative care. And many of them find that the real hook that keeps them involved and keeps them interested. We try and then ensure that the trainees all have to come for an attachment, and then they all have to attend a mandated annual update program as well, which again just keeps the language going in terms of trying to keep the interest. And I think, yeah, I think all we can do is keep trying to highlight just what an amazing subspecialty it is, and the way that for, as I say, it's mainly imaging cardiologists we have within our local networks, and it gives them a cohort of patients that are long-term patients that have fabulous imaging opportunities for them.
So Grisha has, along with this question, so first of all, say what an outstanding talk. So he asks that, do you think that there is a minimum population of patients that clinicians should have access to in order to maintain their expertise? So in other words, do you there is a patient physician ratio that that is optimal to be able to look after patients with congenital heart disease?
So that's a great question. I think that in paediatric cardiac services, their standards defined that they had to have a population, I think, of 1,500 per cardiologist. That hasn't been defined within adults. I think that when you look at the specialist service model within the UK, each of the services has somewhere between about 5 and 7 million of a population catchment. And that probably gives you about the right number of adult congenital heart disease patients with moderate to severe type conditions, and also the number of interventions, surgeries, and the likes that is likely to be required to maintain the needs for your interventionists and cardiac surgeons.
So, any other questions? So, just another question. This is going to be quite controversial. So, I was in the I trained in the UK and very familiar with the UK system, and the guidelines, both the UK American guidelines, recommend 2 years of training for having for being entitled to look after patients with heart disease, or to be recognized as other congenital heart disease specialist. But do you think there is any, or I think there is some room to train people for less time, so for a year, and just for not looking after patients in referral centers, but these kind of people that can be these people in the peripheral centers that we can use as a network population to decant our less complex patients. But that's what do you think about that idea?
The language is very difficult, isn't it? That it's not about decanting your less complex. It's about sharing.
About sharing.
Yeah,
sorry.
but no, yeah.
You're right. You're right.
Sorry, I say it just because it is a point of contention that it is about a shared care model. And in reality, if my patient falls over and breaks their leg in Inverness, they will be taken to the local hospital in Inverness. So having somebody there who has, as you say, about a year's worth of exposure to ACHD care gives them a great specialist level, that they know what they know, but they also know what they don't know and where they want to share and refer on for more expert level care. And so I think that year-long fellowship, which potentially can be interfaced with imaging, or something else that lets them have lets them be an attractive, employable candidate in local centres, is a great idea.
I think we have to start thinking about developing 2 types of fellowship: the fellowship of ACHD fellowship that we know and many centers have, but I think we need to start to develop a program, as you said, that is tailored to develop a cardiologist with an interest. That's something that exists in the UK, and I like this. At the beginning, I didn't understand it when I worked in the UK, but I like that idea of a cardiologist with an interest. But you need to train them.
But I think at the same time, sorry, Rafa, but I think it's also about that we need to try and find. Looking at that projection, we need to find a way in which our patients with moderate complexity lesions can have high quality imaging in a non-specialist centre that allows translatability. So I think it is about developing things like protocols for review schedules, protocols for imaging and reporting, so that there's real opportunity to try and take forward much more standardised care that I think would be of benefit to the patient also.
I totally agree, and I think that's what you said in your first slide. This is not just about clinicians; it's about a big team of. We cannot do our job without all other members of the team, and it's just we need to develop a group of interest in congenital heart disease, and that's what I think we need to do. So Grisha has another question. So the issue of international collaboration seems to essential to maintain standards, and this evolution you speak of. What do you think that are some of the next steps to advance this to a greater extent, the international collaboration?
Yeah, so I didn't get on my high horse about data, which you'll all be very happy about. But I think that we probably need to agree what a sort of core data set would be that would allow us to have translatable data across different healthcare systems, that lets us look at things like deprivation and its impact on healthcare, that lets us look at at all the aspects around the patient's journey. Because just now with an adult congenital heart disease, if I see a patient, for example, with hyperplastic left heart, I had a woman in last week, she's having a very difficult, challenging time. She's asking about her future. Of course, I don't know her future because we don't have 40, 50, 60-year-olds. You try and translate from a Fontan maybe who's 40. We've all seen the data that gives, you know, equivalent ages. And I think it's very difficult because that's advising you about what a Fontan's doing now. But that may not be the case. If she's 20 just now, that might not be the case in 20 years. So we need to try and achieve more collective collaborative data that really takes forward some of the research that's already been published, but translates it and keeps it up to date, because I think it needs to be contemporary to the patient population. So I think in terms of trying to maintain standards and look towards opportunities to evolve and develop, it would be really helpful to have a core data set that we could try and robustly interrogate going forward.
I agree. Any other questions? Okay, Niki, if there is no more questions, I could keep asking you questions, but there's gonna be Lucy has a question. So I agree, it's a fantastic field with great potential to spark a trainee's interest. However, growing that interest and developing a career is much easier in a UK model for consultant funding. It's tricky to get North American trainees interested in a career in ACHD in a fee-for-service model. Absolutely agree with Lucy. So that's that. We have a model in North America of a fee-for-service, and ACHD is not as attractive as doing general cardiology. In a model where you are in a salary model, it's easier. Definitely agree with Lucy on that comment.
But I think that's a huge challenge for North American healthcare about long-term conditions of all types. You know, I think it's a huge question.
But I think we have to work towards that, and probably just ACHD should be one of these models that should be supported by the government, and that can be done on the side of the Atlantic as well. So I think we have to reinvent ourselves. I think, and I'm thinking that the problem with ACHD is the population. I think we are facing facing or dealing with our own success. So now we have a group of patients that 20 years or 30 years ago they didn't survive. Now they are alive, they are here, and the problem is that they can't stay and they never leave because we are getting better in what we do, and that model is not longer sustainable, because otherwise it's the resources that you need to keep your referral centers running are absolutely not achievable. So I think we need to think or start thinking about a new model, but the next 10 to 15 years are going to be extremely challenging to maintain the current model that we do. I think you in Scotland have it already, and that's one of the main reasons that I wanted you to give this talk. And I think that the rest of the centers, we have to start to think about how to evolve to something like that. But I agree with Lucy, it's more challenging on this side of the Atlantic. And as she mentioned, something very important comment, some people here leave the medical school with a massive debt, and so they have to really have a job that they get enough money to pay the debt. Any other comments or questions? Erwin?
I thank you very much, Niki, for an excellent talk and very thoughtful talk, and in particular, not only for the young or the new generation of ACHD physicians, but also for all of us, for the senior ones. I completely agree with you and with Rafa. To the next 10 or 15 years, I think we have to reinvent or reshape the ACHD field, how we provide care to this rapidly growing population. The population will grow in the next 10 to 15 years, that's what I predict. Then we will reach a plateau, as we do have in pediatric cardiology. And a challenge will be the shared care model, shared clinic. As you said, in Scotland, it's much easier than in Canada with these very long distances. but I think we need to train we need to train physicians, cardiologists, so that they can provide care for patients with simple congenital heart defects in a collaborative care model, because I'm convinced that each congenital heart disease patient should be connected and attached to an ACHD center. It's not only the physician then in the community, but it's also the cardiovascular imaging, for instance, the echocardiogram, how to image these patients in the community with sonographers, so that you have a good quality images and echocardiograms, so that you can make any reasonable conclusion from the tests. And there's also mentioned during the presentation, even during the discussion, that we need standardized protocols how to image these patients with simple and complex congenital heart defects. But actually, there are protocols. There's a position statement from the International Society for Adult Congenital Heart Disease, which was published, I guess, 2 years ago in 2018 in the International Journal of Cardiology. The project was led by Wei Li from the Royal Brompton Hospital. I guess Crucial was also involved in this project. And yeah, that's the first step, but to have position statement and some standardized protocols for the community how to image this patient. But the key is, if a patient is following the community, these cardiologists need to have a collaborative connection with an ACHD center to maintain the quality of care.
Thank you, Erwin. So, Niki, I think just congratulations for the model and congratulations for the job. I know that it's been very challenging for you to maintain this, and also enjoy the next year, that your team has grown significantly in a short period of time with a very important and world-leading people in the field joining the team. So, and thank you for joining us today. And
thank you for the invite.
No, that's so. We this is the last session of the year. We will be back next year. Actually, in January we'll have Magis on the call, and she will be giving a talk in January. And we'll be back next year with more exciting sessions and new challenges for the field. So thank you very much for joining us all. I wish you a happy holidays or Merry Christmas, depending where you are in the world, and good morning, good night, or good afternoon, wherever you are in the world. See you next year. Happy New Year. Bye, Niki. Take care.
Thank you. Bye-bye.
Bye.